leak, which eventually decreases the systemic vascular resistance, causing most important element or the clinical sign of sepsis, which is hypotension. And we know that if an organ is not perfused correctly with the amount of blood, it results into tissue hypoxia. Because if I take away the blood supply of any organ due to hypotension or due to low supply, which is seen in which is mostly seen in hypertension, what it will result into tissue hypoxia. And once tissue hypoxia is there, there is that the Krebs cycle is reverted, the non-oxidative oxidation starts, and there is accumulation of lactic acidosis due to tissue hypoxia. And this lactic acidosis, once it crosses the normal level, because lactic acidosis can also take place once you are exercising, once you are doing anaerobics exercise, which requires high input of the body, high oxygen demand. Lactic acidosis is also there in those cases. But out here, this is pathologically increased amount of lactic acidosis, which eventually turns into organ failure. And then advanced stage of all this, once all this is going for a long period of time, it will eventually develop into a more advanced stage, which will lead to septic shock, which is a life-threatening condition, which we'll be discussing shortly and how to manage it as well. Am I clear up till now? Is there any question? Since I won't be able to read the chart. If anyone have any question, they can unmute themselves and they can ask it while I'm discussing the slides. So moving forward to the clinical signs for sepsis. So how would you eventually know that which patient can have sepsis and which patient requires further evaluation to check that if that patient has sepsis or not? So most common symptoms, everyone that comes to the most of them, apart from patients of stroke, they will complain of fever. We all know that fever is there as a sign of infection, but do we know that hypothermia can also be a sign of sepsis? This is a very important thing which is not seen clinically in our setup, because we have a lot of number of patients. If someone complains of fever, we check it. If they don't, we do not mention it. But eventually, hypothermia is very important. So whenever you inspect the patient, you go for the temperature check as well. You have to check their peripheral limbs for the temperature. If you sense that they are suffering from hypothermia, this will be one of the sign of sepsis, and then you have to evaluate the rest of the things. So the rest of evaluation depends upon the vital. You go for the pulse. If the pulse is tachy, greater than 90 beats per minute, this again checks a box, moving towards that the patient can have sepsis. Then tachypnea. Tachypnea is also a sign of developing sepsis. So if a person who is having for new first year and second year student, tachypnea eventually is the increased number of respiratory rate, So late signs that has to be seen is cold, clammy skin, very important. Again, as we just mentioned earlier. Now, instead of tachycardia, if you have a weak pulse, you do not feel the pulse, and it is like very weak, feeble pulse, you are unable to feel it. So it's a very first sign of hypotension, because once you have hypovolemia, eventually your tachycardia that was taking place initially is now getting very because of it's now out of energy. So the heart is going out of energy. It is exhausting itself. So eventually it results into a weak pulse. And then once the body is unable to compensate, the examination, looking for anemia, looking for joinders, looking for pulmonary, looking for cyanosis, looking for the JVP roughly, not calculating it, but just telling the patient or moving the neck of the patient sideways to see any increased JVP is there or not. So then we follow the entire criteria of CNS examination, respiratory examination, cardiovascular examination, and then abdominal examination and so forth. So how would you see organ dysfunction in a patient? That is very important. So organ dysfunction in a patient will be judged by the clinical symptoms and the signs that you will see there. If you're standing next to a patient who's suffering from sepsis, these things has to be noted. Check first for the brain. Check first if the patient is in confusion. If the patient is in altered sensorium and the patient is in agitation. So how you will differentiate that? What is confusion? What is altered sensorium? And what is agitation? This is very important. So when we go through the books, we read these out there, these words of confusion, altered sensorium, and agitation. But we really don't know unless until we see a patient that is confused, when we see a patient that has altered sensorium, and we see a patient that is agitated. So I'll start first with the agitation. Agitated patient, if you guys can imagine, I would later on I will send you a link in which you can see an agitated patient, in which you can see an altered sensorium. A patient is a patient who is in altered sensorium, and then a patient is confused. So agitation looks like a patient is uneasy. He's moving his limbs. He's moving his limbs. He's even shouting around. He's trying to he's trying to show that he's very uneasy. So that is agitation. But he's recognizing people. He's telling people that I'm not feeling comfortable. He's telling the names of the people who have brought him to the emergency. So that will be agitation. What about altered sensorium? So this is very important to pick in a patient. Altered sensorium is that a patient is there. He's very quiet, and you don't take that quietness as being that patient is just lying down very comfortably. He has his eyes open and he's fine. He's just patient will you don't think that the patient is just sleepy, or attendant will give you history like that patient did not sleep for the last 1 or 2 nights, so that's why he's like that. But you have to check for it. In cases of altered sensorium, patient will not be responding to you. Patient will not recognize the attendants that they have brought him to the emergency. Patient will not be able to tell you the time and the place where he is at. So orientation will be distorted in case of altered sensorium, whereas orientation will be intact in agitation. And now talking about confusion. So moving forward to the clinical signs for sepsis. So how would you eventually know that which patient can have sepsis and which patient requires further evaluation to check that if that patient has sepsis or not? So most common symptoms, everyone that comes to the most of them, apart from patients of stroke, they will complain of fever. We all know that fever is there as a sign of infection, but do we know that hypothermia can also be a sign of sepsis. This is a very important thing which is not seen clinically in our setup, because we have a lot of number of patients. If someone complains of fever, we check it. If they don't, we do not mention it. But eventually hypothermia is very important. So whenever you inspect the patient, you go for the temperature check as well. You have to check their peripheral limbs for their temperature. If you sense that they are suffering from hypothermia, this will be one of the sign of sepsis, and then you have to evaluate the rest of the things. So the rest of evaluation depends upon the vital. You go for the pulse. If the pulse is tacky, greater than 90 beats per minute, this again checks a box moving towards that the patient can have sepsis. Then tachypnea. Tachypnea is also a sign of developing sepsis. So if a person who is having for new first year and second year student, tachypnea eventually is increased number of respiratory rate, number of respiration in a minute, increased number of respiration per minute is tachypnea. So if a person is doing inspiration and expiration for greater than 22 times per minute, that is considered as tachypnea. So that is also one of the signs for uh, that is also one of the signs for sepsis. And then warm peripheries. If a patient who have fever, tachycardia, and who is not having hypothermia and have warm peripheries, you always check the temperature of the peripheries. If they are hypothermia, then that is also important. And if they have warm periphery, that is also important because it can be an early sign of septic shock. So we know that these four things are important. So fever, we know that there's an infection going on, or there's some response, there's something going in the body that is responding, and body is giving the first sign that something is not right, which is fever that mostly occur. Or in older cases, in patient who are elderly, their inflammatory process is not that powerful as compared to young ones. So they do not go for hypothermia. They will eventually develop hypothermia. So you look for that in that. Then tachycardia, again, the body is suffering from a lot of amount of toxins, so it has to work a lot, and to work a lot, it requires a lot of blood. So the heart starts pumping blood, so that those the pathophysiology which we just talked about, the initial compensation stage, when there is capillary leak and decreased vascular resistance, so the body tries to compensate for it. So that eventually increases the heart rate, resulting in tachycardia. And then comes again tachypnea. Once again correlated with the pathophysiology. Once there is lactic acidosis, body is assuming that there is hypoperfusion. When body is assuming there is hypoperfusion, there is lactic acidosis going. Why there is anaerobic oxidation of things going? So it sense it the brain sense that there is lack of oxygen, though although it is not because of the normal process of anaerobic oxidation, it is because of the sepsis that is resulting into lactic acidosis. So again, body due to hypoperfusion, body tries to uh, gather oxygen, resulting into tachypnea, increased respiratory rate. And lastly, warm periphery is because of the tachycardia, which eventually results into increased amount of blood flow initially. So that's why it is mentioned that it is early septic shock when there is warm peripheries in the patient is coming with these symptoms. So the late signs. Now this is very important. Decompensated or cold shock. So if you see a person having all these, now this is an alarming sign. This is a thing that has to be addressed, and the patient has to be seen very thoroughly, because these signs are very important to catch, because this eventually can result into severe sepsis, then eventually septic shock, and may prove to be fatal. So late signs that has to be seen is cold, clammy skin, very important. Again, as we just mentioned earlier. Now, instead of tachycardia, if you have a weak pulse, you do not feel the pulse, and it is like very weak, feeble pulse. You are unable to feel it. So it's a very first sign of hypotension, because once you have hypovolemia, eventually your tachycardia that was taking place initially is now getting very because of is now out of energy. So the heart is going out of energy. It is exhausting itself. So eventually it results into a weak pulse. And then uh, once the body is unable to compensate through the tachycardia and tachypnea, it results into severe hypotension. And then the second thing we just discussed earlier, once the patient develop tachypnea to compensate with the lactic acidosis and hypoperfusion that is going on. If that is not compensated by the body, it will eventually lead to cyanosis, and cyanosis will eventually be will strike in because body is unable to compensate with that inflammatory process that is requiring energy, uh, a lot of energy for for the process. And eventually, if these are the things that are going on for a long time, the body can also develop DIC, which is bleeding in petechiae. So, a patient who's coming with cold, calm scheme, having a weak pulse, having hypotension, and you also see different patches on the skin, petechia, that are small purplish or reddish patches on the skin. Then you can suspect that this can be eventually late outcome of sepsis, which is eventually developing into a DIC. So, which is very important, and this is also very lethal. DIC can kill a patient within hours. And finally, when all this is there, multi-organ failure results. When body is unable to compensate with all things, all these things are there, signaling towards the multi-organ failure. We'll discuss about how in the next slide we will be discussing how multi-organ failure can be picked in such patient. So organ dysfunction, why it is important, and if you suspect all those signs that we just discussed in a patient, what to see next. So we have an entire protocol that we follow in ER. That is, once we start our examination, we just roughly do the general physical examination, looking for anemia, looking for joinders, looking for colonychia, looking for cyanosis, looking for the JVP roughly, not calculating it, but just telling the patient or moving the neck of the patient sideways to see any increased JVP or is there or not. So then we follow the entire criteria of CNS examination, respiratory examination, cardiovascular examination, and then abdominal examination, and so forth. So how would you see organ dysfunction in a patient? That is very important. So organ dysfunction in a patient will be judged by the clinical symptoms and the signs that you will see there. If you're standing next to a patient who is suffering from sepsis, these things has to be noted. Check first for the brain. Check first if the patient is in confusion. Is a patient is in altered sensorium, and the patient is in agitation. So how you will differentiate that? What is confusion? What is altered sensorium? And what is agitation? This is very important. So when we go through the books, we read these out there, these words of confusion, altered sensorium, and agitation. But we really don't know unless until we see a patient that is confused, when we see a patient that has altered sensorium, and we see a patient that is agitated. So I'll start first with the agitation. A agitated patient, if you guys can imagine, I would later on will send you a link in which you can see an agitated patient, in which you can see an altered sensorium. A patient is an patient who is in altered sensorium, and then the patient is confused. So agitation looks like a patient is uneasy. He's moving his limbs. He's moving his limbs. He's even shouting around. He's trying to just he's trying to show that he's very uneasy. So that is agitation. But he's recognizing people. He's telling people that I'm not feeling comfortable. He's telling the names of the people who have brought him to the emergency. So that will be agitation. What about altered sensorium? So this is very important to pick in a patient. Altered sensorium is that a patient is there, he's very quiet, and you don't take that quietness as being the, oh, that patient is just lying down very comfortably, he has his eyes open, and he's fine, he's just patient will you don't think that the patient is just sleepy, or attendant will give you history like that patient did not sleep for the last 1 or 2 nights, so that's why he's like there. But you have to check for it. In cases of altered sensorium, patient will not be responding to you. Patient will not recognize the attendants that they have brought him to the emergency. Patient will not be able to tell you the time and the place that where he is at. So orientation will be distorted in case of altered sensorium, whereas orientation will be intact in agitation. And now talking about confusion. So confused patient will be differentiated from agitated patient by the fact that he would not be able to tell either he's uneasy or not. He will talk to you, but then he will talk something irrelevant. If you ask him about what is happening, what makes you come to the what makes you come to the emergency, so he would be responsive, but then he would not give a correct response. He will tell I had fever, but now I'm fine. Then he will shift his answer completely to a different answer. So that will make you understand that this patient is confused, and this can be a sign of hypoperfusion and brain dysfunction. So these three signs are the clues that dysfunction or the perfusion of brain is being affected and the patient is developing an organ dysfunction. So moving towards I hope this is clear with you guys about, because this is very important. We mostly neglect this part of the examination because we have a lot of patients at the ER. So we have a lot of less time. So we do not get most of the time to talk the whole thing. But if you have a patient who has the previous signs, who is showing the previous symptoms of hypertension or tachycardia or tachypnea or hypotension or TH. So you need to assess this to see that either the organ dysfunction has kicked in or we still have time. So moving forward to the next system, that is cardiovascular. What you will see again, it's very simple. If a patient is having hypotension, that's an alarming sign for everyone. Now you need to treat that hypotension, and hypotension is eventually a sign that the heart is getting exhausted. It was techie before when you didn't see the patient, or he was on the way, or it has been a long time that he has been suffering from sepsis. Now it is incoming in organ dysfunction that is evident through the hypotension and narrow pulse pressure that will eventually tell you that the cardiac system is being compromised. And then comes the other organs that includes liver, hepatitis, and cholestasis. This will eventually be not be seen evidently once if you have jaundice. In case that you have jaundice, you can consider that now the dysfunction from the liver is taking place. It can be because of hepatitis. It can be because of cholestasis, and then this is a very important thing, which is renal dysfunction. Renal dysfunction will be characterized by oliguria. Oliguria is termed as 0.05 ml per kg per hour. So this is very important. If you see a patient and having all these signs of sepsis, you first of all go towards passing the urinary catheter, that is known as Foley's. Once you have the Foley's in place and you do not see any output in the entire through the entire time, since the labs around in Jinnah takes around 2 to 3 hours to come. So before that, we'll see this. The next part is very important. Before that, you go for the ABGs. So if you have passed the Follies and there is no urine output, and you wait for the labs, eventually, since you don't have any urine output, the creatinine levels will be raised, showing renal dysfunction. And this is the most important thing that should be that is addressed more quickly. Even when you are confused that either I don't have time. What in our setup we do not have much time, so I can't. If I have 50 patient at the ER and the ER is heavily crowded, so I can't have the entire time to evaluate every patient. So patient whom I think that can have sepsis and has all these elements, I'll first of all go for the ABGs. So patient who shows any sign, when you have even the slightest of hint that the patient might suffer from sepsis, tell your house officer or tell yourself that you have to go for the ABGs. This is the most quickest and the most reliable test that can tell you a lot about the patient, especially when there is once you go for the ABGs, its results are there in within 15 minutes. Till then, the follies will take place, the NG will take place if there is altered sensorium and all these things. And then once you have that ABGs in your hand, within 15 minutes, you can assess through metabolic acidosis. How to assess how severe it is? According to the if there is severe metabolic acidosis, there is severe sepsis taking place. If there is milder or moderate metabolic acidosis, then you can analyze that what kind of situation I am facing in such patient. So milder or moderate sepsis should not be left very should not be ignored, but has to be treated. But if you are having severe sepsis in a patient, you have to take ICU on board, and that's a life-threatening condition. So moving forward, if you see severe sepsis, severe metabolic acidosis on the ABGs, now you're suspecting septic shock. As I just mentioned earlier, that is a life-threatening condition. So septic shock, just by the definition, is a life-threatening advanced stage of sepsis, along with persistent hypertension, as mentioned earlier, which is a sign of organ dysfunction. Systolic BP will be less than 90 mm of Hg, and severe organ level damage will be there. Organ damage you can be assessed through the labs that will be there, or the clinical signs symptoms we just discussed earlier. Now what to do? Now you see that there is metabolic acidosis and patient had an history of fever, or patient is currently having fever, or patient is old age is having hypothermia, patient is tachypneic, patient is tachycardic, or patient is hypotensive, patient is developing petechia. Now you know that this is on the clinical grounds. You can judge that this is septic, and a patient is now is there at the ER with hypotension and having all that history points in the background. And now you see that there is hypotension. You will suspect that it is a septic shock, and you will treat it in the lines of septic shock. What you will do, you will start the vasopressor. Vasopressors. Mostly in our setup, we have noradrenaline, which comes under the name of Levofit, that is mostly started in a pediatric chamber. That will eventually learn in your house job. And high serum lactate level. See, sometimes out there in JPMC, we especially have to call for the lactate level. We do not readily get them through the ABGs. In the ABGs, we go for the metabolic acidosis. So metabolic acidosis can also be there in case of AKI. So, in case of AKI, how would you differentiate that it is due to if a patient is having fever, he had acute gastroenteritis that eventually resulted in fever, and the patient is coming to you having altered sensorium, hypotension because of volume depletion, loose stools, and there is no urine output. How we will differentiate this patient that this is a patient of AG, this is hypovolemia because of AG and not septic shock, is by the lactate level. If you have any confusion between this, that this can be AKI that is resulting into hypovolemia. Uh, this is due to loose stool. Hypovolemia is because of loose stool, which is eventually resulting into AKI, resulting in no urine output. In such cases, to differentiate, we assess the serum lactate level. And again, to assess exactly the situation of sepsis, we go for the lactate level. If it is greater than 2, the patient is in septic shock. It is lower than, and if it is lower, because if it is lower than 2, it is not a septic shock. Things are still well, and we still have time. So why this lactate level is mentioned over here? See, when you go into the ER and when you're assessing the patient, it's not a simple patient who will come with no previous comorbidity. You will have patient which will have heart failure. You will have patient with heart failure will eventually come with hypotension. You will have patient who will have CKD, so they will eventually have a you will have a lot of comorbidities that will be there. And to differentiate them from the sepsis element, lactate level will play a role in that. So if a patient has lactate level greater than 2 millimole per liter, uh, you need to this is a best sign, and this is the most evident sign of septic shock. You will start with the vasopressors and will try to improve the blood pressure of the patients. Because why we have to be quick in this, because the mortality rate in such septic shock will jump up to 40 to 60%. So when to suspect emergency? As we just discussed earlier, suspected infection history, respiratory greater than 22, systolic blood pressure less than 100, hypotension, tachycardia, altered mentation. So these are the these. There's an entire Q-SOFA score once you are into clinical aspect of your um, medicine. You will see that we have created different score, such as you have the curve 65 score for admission criteria in pneumonia patient and elderly. So similarly, there's a score known as Q-SOFA criteria, that if a patient have all these four, and if the score is greater than two or more than three, that triage is done and the patient requires urgent ICU care. So that's how you differentiate. Alternmentation is there, systolic pressure is less than 100, respiratory rate is greater than 22, and there is suspected infection. Then the Q-SOFA score will eventually guide you further that where you have to place the patient. Either if the patient is in of can be managed in general ward, either the patient requires high dependency unit, or either the patient requires intensive care unit for treatment. So common emergency cases, pneumonia. For pneumonia, you will see all this thing. In pneumonia, the TLC count might not rise that much, but if a patient who has cough, who has history of fever, who has productive cough, that has color, patient is tachypneic, you get an X-ray done. You see that there is a patch on the X-ray. You get the ABGs done. You see that there is severe metabolic acidosis. Then you can say that this is sepsis secondary to pneumonia. Again, very common UTI, especially UTI develop initially in the initial stage. It is known as UTI. You get an urine DR done. You see the leukocyte estrase level in that. You see the leukocytes there. If that are positive, and patient again is you go for the ABGs. You see metabolic acidosis. Then this UTI converts into urosepsis, providing the fact that all these criteria is back there. You have the Q-SOFA score, you have the TSC count increase, your urine DR shows leukocytes and leukocyte estrase positive. And that is the whole criteria for labeling that patient as having urosepsis. Then intra-abdominal infections, spontaneous bacterial peritonitis, other cholecystitis can also lead towards liver abscesses, can also lead towards, if not treated or not detected early, can lead towards sepsis and even septic shock. Skin and soft tissue infections such as cellulitis, if not treated in initial stages, uh, eventually the patient comes to the emergency with a whole septic situation because this cellulitis has grown so much that it eventually results into sepsis and septic shock. So, see, whenever we are standing at the ER of medicine, most of the patients that we get are treated from the quacks, are treated from herbal medication, are self-treated even. So you will even find patient who will just go to the pharmacy department and they will get a medicine from there and won't see a doctor. And once if a patient is coming into the JPMCR, you know that that patient is coming at the most severe level that he can, because before that they do not care to come to the hospital, except for some cases that are seen in at the OPD. And lastly, the common emergency cases is meningitis. Meningitis, again, as we just talked earlier, altered sensorium confusion. If you're suspecting altered sensorium is there, confusion is there, or there is agitation, again, you will suspect of meningitis. TLC count will not rise in case of meningitis. You will go for the signs of meningitis, which is done in CNS examinations such as Burdensky's and Kerning signs. And if you suspect that there is meningitis, the next thing is performing the lumbar puncture LP to either diagnose which kind of meningitis it is. Which and even meningitis can lead to, if not treated for a longer period of time, it will eventually lead to sepsis and septic shock, because you need all these are the source of bacteria and source of toxin. If not treated, they will eventually multiply and multiply to a level that will take the body into septic shock. So, You have seen all these patients. Now, the initial assessment that we all always say once we have asked about it, that how we will manage the patient. Again, ABC. What is ABC? Airway. You will protect the airway. GCS, Glasgow Coma Scale. If your patient, you go through the eye, verbal, and motor components of the patient. And if it is less than 8 and patient is drowsy and patient is unresponsive, so you go for the airway protection. How do you protect airway? You protect airway through a Gudel tube. You get the patient, you go for the nasal gastric tube, you go for the NG tube placement so that the patient might not aspirate. And if the GCS is very low and there is also loss of saturation and there is decreased saturation and the patient is either developing decreased respiratory rate or is very tachypneic, then you will consider the patient for intubation as well. So breathing. Then the second part of initial emergency management, you will give high flow oxygen. Again, high flow oxygen can be given in different ways. Once you go with the full mm, oxygen mask. If again on that oxygen mask the patient is not maintaining the amount of saturation which is greater than 94, you can go for the non-rebreather mask with the valve opens to give high flow oxygen. And if again if that is failing and patient again is not maintaining saturation and it's tachypneic, then if the patient have GCS is have a GCS greater than 10 and it's oriented, you can go for the BiPAP or CPAP. First the CPAP, then the BiPAP. And again, if the patient with all these sessions fails to maintain a saturation of greater than 94, then the only thing that you have is left is intubation and ventilatory support. So initial management in circulation, because there is hypotension, you need to use two large bore IV cannula, one for the hydration purposes, where you will push in the fluids. You will give boluses of 200 ml at full speed, and the other will be there to start the inotropic support. That can be levofit, that can be dopamine. We would discuss in the upcoming session that how we will eventually have to, how we will manage all these there in the ER, how will we make the support, what are the fluids that we'll initially give, what will we give after normal saline or bolus. If the boluses does not work, if the fluid challenge does not work, what we'll go for next. And then cardiac monitoring is important. You will have a good eye on the cardiac monitoring. You will see either the blood pressure is rising or not, either still there is hypotension, BP monitoring is there. Disability, again, checked earlier, GCS for disability, either the GCS is improving by your treatment or not. What is the GCS? And you will have the baseline GCS. Check glucose, very important, because sometimes hypoglycemia can also result into altered level, and then any kind of exposure to danger is important. Any kind of exposure to any drugs or anything else should be also ruled out. So, golden hour. As we just discussed, once your ABG is there and you have gone for the lactate level, it comes greater than 2 millimole, you know that this is this is septic shock. And once you know that this is septic shock, you have to be very quick in this management. And you have to, again, you have to send the blood culture there and then only, then start IV fluids. As we talked earlier, 30 ml per kg isotonic crystallite, either normal saline or ringer lactate. If you suspect there's no history of CKD, there is no history of renal impairment, you can go with ringer lactate. Or if you suspect that there is swelling, bilateral pedal swelling, there is perfuse anasarca, the urine output is not that adequate once you're giving the fluid, and the history of CKD, you can go safely with normal saline. And again, give rapidly. Yes, since we are talking about giving IV fluid at a rate of 30 ml per kg, we have to give it very rapidly, uh, because the patient is hypertensive, and we have to increase it in boluses if the lactate level is greater than 4. Mean arterial pressure after fluid should be assessed. If the mean arterial pressure is less than 65 mm of Hg, even after the fluids that crystalloids that we have given, we have to start vasopressors. This is very important. And the first line, as we just discussed, is norepinephrine. And the goal of that vasopressor is to elevate BP to a level of 110 to 120 by 80 or 110 to 70 B range. So this is very important. That's why it is termed as a golden hour. That you have to be very quick in sending the blood cultures. You have to be very quick in giving the fluids, and you have to there and then assess that either the fluids are working or not, either they are maintaining the MAP mean arterial pressure or not, and if not, then you will take the patient to the first line of treatment, the inotropic agents, the support agents, which will help to maintain the mean arterial pressure. So high mortality, you know that any patient suffering from septic shock having higher lactate levels should be referred to ICU admission. And once the patient has been given the initial golden hour treatment, then we will move towards the source of infection and getting the source of infection out from the body. Which is in case if there is abscess, because in case there was a skin infection, cellulitis, which eventually went on to become an abscess, we need to get this source of infection out of the body. So we'll drain that abscess. Obstructive kidney disease, if there is no urine output because of any stone and that the accumulated urine is now becoming septic for the body, we need to remove that obstruction in order to treat the sepsis. Because if you don't take out the source from the body, such as these sources, which can be which can be the source of infection, we have to take it out. So once you have to relieve the obstruction in either to cure sepsis or septic shock. So infected line, yes, again, patient uh, who are suffering from chronic diseases are mostly cannulated for a longer period of time. So you need to be very vigilant in such patient who are bed bound or being treated at home by IV antibiotics or IV fluids. You need to know that when was the last time the IV cannulation was changed. And if a patient is being referred from another hospital, again, you have to be very cautious about the IV line, because IV line has to be changed every 3 to 4 days, or even in this immunocompromised patient, it has to be changed every second day. Now, again, if the patient is developing peritonitis because of SBP, because of intestinal obstruction, you need to go for surgery to remove the source of inflamed peritoneum. Now, so the source control, this has to be done ideally once you have admitted the patient in ICU, and you have, if you find any of these, you have to treat this within the next 6 to 12 hours, because making it late will eventually be giving time for sepsis to increase. So routine monitoring, again, as we talked earlier, urine output is very important. The advocate urine output will help us, will eventually tell us that the patient is coming out of hypotension. That should be greater than 0.5 ml per kg per hour as a target. Lactate clearance, you should see that once your antibiotic is there, once your vasopressor is there, the lactate level is coming down. It is less than getting less than 2 MAP is mean arterial pressure is rising greater than 65. The mental status is becoming better. The patient is out of confusion. The patient is out of sensorium. The GCS is increasing. That is also a sign of uh, improvement in the patient that is being treated for sepsis. Then again, ABGs, as I mentioned earlier, the metabolic acidosis that was there previously is now improving. So the backup level is improving. If the backup level was 10 previously and now it is 15 or 18, that is another sign that you are treating the sepsis well and the patient is coming out of danger. Again, all these things are deteriorating further. That means you are losing time and you might lose the patient. Again, creatinine, since there is hypotension, the first hypoperfusion strikes, the first organ that the hypoperfusion strike is the kidney. So first, the creatinine, if the creatinine is improving, that's again another sign that you are treating the patient, the sepsis is being treated well. And if all these things